Can you hear me at the back? First of all, a very warm welcome to everyone on behalf of the Royal Society of Arts and the University of Hertfordshire, and thank you all for taking the time out of busy lives to join us tonight. The RSA is particularly grateful to the University and the Department of Education for their generosity and support in facilitating, free of charge, this event, Unleashing Potential, Crucial Beginnings. Now, I'm going to read these few notes, and they'll only be brief, because this is my most passionate subject. And if I'm let loose, you'll all be here at about midnight. So forgive me, I'm going to keep on track and just tell you the background to why we're all here tonight. The Royal Society of Arts began in the coffee houses of Covent Garden in London in the 1700s, and following in the tradition established at that time, has as one of its central aims today the encouragement of conversation and discussion by bringing people together to share innovative thoughts and ideas, to shed a greater light on some aspect of society where problems are experienced. The hoped-for result of these exchanges, with shared knowledge at their heart, is to start a movement towards action and change for the better. So tonight's lecture and forum provides an opportunity to enlarge a conversation begun at an RSA function last year about how to focus a spotlight on the needs of high-functioning young neurodiverse children who may have exceptional intelligences, which are not always evidenced due to their challenging behaviour in school and at home. Even though there is so much good intention around to support their needs, we seem to have difficulty finding a clear pathway to diagnosis, with a serious lack of knowledge in some areas about how to spot these traits of neurodiversity and differentiate their behaviours from those of children who challenge for different reasons. We have the unique opportunity this evening to listen to expert speakers to grow this conversation by questioning a panel of representatives chaired by Sue Hind-Woodward, who has stepped in, another fellow of the RSA, at the last minute as John Cooper, our chairman, was not able to come. So thank you, Sue. We're going to share ideas and good practice, problems and frustrations on the topic, Unleashing Potential, Crucial Beginnings. I think the fact that everyone here tonight is giving their valuable time free to come to the event exemplifies how passionately people feel about this subject. So in this introduction, I would like to explain that the strong rationale for being here is all in the title of our event. You will hear from our speakers about the quirky, outside-the-box behaviour of high-functioning young neurodiverse children, their acute anxieties, their eccentricities, sometimes mercurial of mood, hysterical, angry, hyperactive, or withdrawn. Whilst they share certain traits, they are all as different and individual as snowflakes in a storm. In their patterns of behaviour, they struggle and suffer, trying to be accepted with little understanding of where they are going wrong. Without recognition and understanding, their often exceptional intelligences are neglected, they become disaffected and more disruptive or withdrawn, and so the vicious circle which traps them begins. Later in life, with no outlet for their potential talents, mental health issues often follow. This is not a simple situation, nor are there simple solutions. Hence the needs for us to put our thoughts together tonight. The raw facts are that with health budgets ever tightening and schools increasing in size, many young, high-functioning neurodiverse children are not getting the diagnosis, understanding, and support they need and deserve early enough in childhood. There are fears that after diagnosis, there won't be the funds to underpin further support, and that false hopes may be raised. Perhaps we need to be less afraid of labels and understand how, when sensitively labelled and never used as an excuse, they can be useful. A label lets a child know that their disability is not their fault, and that their problem has a name. It lets them know that there are others out there like them. It allows them to build a positive self-image based on acceptance and even celebration of their differences. So, a few names from the past to throw into the air, randomly chosen. Sir Isaac Newton, Albert Einstein, Vincent van Gogh, Charles Darwin, Leonardo da Vinci, Beethoven, Mozart, Alexander Graham Bell, Thomas Edison, Charles Rennie Mackintosh, Virginia Woolf, Coco Chanel. I could go on, and so I'm sure could you. These individuals, now thought probably to have been neurodiverse before diagnosis was possible, changed the world. RSA Fellows are often elected because of their outside-the-box thinking, their courage and focus in tackling difficult projects. Nobel Prize winners and other leaders in every field of human endeavour usually display traits of neurodiversity. They often had a difficult childhood because they were mislabeled as mad, lazy, retarded, and they can usually pinpoint somebody in their lives who attempted to understand them, helped support their difficulties, and nurtured their strengths. Their exceptional passions were often the platform upon which their aims and successes were built. So, let us hope that our conversations tonight at the close of World Autism Awareness Day will move us positively towards increased knowledge of the traits and needs of young, high-functioning neurodiverse children, and that some action may result from this evening to carry the conversation forwards, to help unleash the potential of exceptional intelligences, gifts, and talents in these children in the crucial early stages of their development. This will help each individual, each family, each classroom, and each school, and perhaps ultimately benefit society. Thank you. It's now my great pleasure to introduce you to our first speaker, Dr. Simon Williams, who has travelled from the University of Chicago to be with us tonight. He is currently Research Associate at the Feinberg School of Medicine, a former Research Fellow at Cambridge University, and currently a Fellow of the Royal Society of Public Health. His focus is public mental health policy and the effectiveness of early diagnosis. Thanks, Simon.
Sure thing. Yeah, it's recording. Okay. That's perfect, thank you. Alrighty. Hi everyone. Let's see if we can get my presentation up as a start. So actually it's a good thing I'm wearing a mic, I think, because I've pretty much spent the last 24 hours on a plane, so my voice is a little hoarse, so please do let me know if you can't hear me or if you want me to speak up a little. So that's the title of the talk tonight. First of all, of course, some housekeeping of my own, just a few acknowledgements. So thanks to the lovely Jenny King for inviting me today and for really providing the energy, the impetus, and the excellent ideas for this forum tonight. Also, thanks to everyone gathered here to kind of, bring this conversation forward, to reiterate what Jenny was saying, and also thanks to the RSA for organizing this and inviting me. I also want to thank Kimberly Dinas, a clinical psychologist in Chicago, who's my kind of co-collaborator on the emotional, behavioral, and mental health screening project. Catherine Roche and Place to Be, so I'll talk a little about what that is. Really what we're talking about is like a post-screening intervention, with Place to Be being what I think is an exemplary model for that. And then I'd also like to thank pretty much everyone here, to be honest, for school professionals who do the work that they do. This also includes my mother. One of my reasons why I'm passionate and could talk all night about this is because my mother used to work with special educational needs children, and really at a time where we didn't kind of understand in the way that we are beginning to understand what neurodiversity is, really work to foster their acceptance and advancement within mainstream education. So thanks to her. And for giving birth to me. Otherwise, I wouldn't be here. So thanks to the RSA and my parents. So just a quick summary then of what I want to talk about. So what I'm going to start off with is the BMJ paper, which really kind of got me kind of involved in this discussion, which really also kind of manifested itself in some kind of public debate in the mainstream media. It's this idea of introducing universal screening in schools for checking emotional, behavioral, and mental health needs and risk. And then, if time permits, just a quick summary of a recent evaluation. Again, this is the Place to Be model, which I think could be a good follow-up to universal screening. Just before we kick off on that, just a couple of prefatory remarks for clarification. So what I'd like to do actually is kind of acknowledge that I'm not an expert in autism, in ASD, in ADHD. I really would like to refer to Tom and Mel and to many of the experts gathered here when we talk about the specifics of those conditions. My background, as the bio said and Jenny mentioned, is in public health. So really what I'm particularly kind of able to contribute to maybe is discussions about the policy implications of screening for things like ADHD. We'll get into maybe some of the specifics of ASD and how that's different in a moment, but it's not exclusively confined to those kind of conditions. However, I don't think it's irrelevant given the scope of tonight, since, as we know, neurodiversity, some argue the umbrella of that term has been extended to include things like bipolar, schizophrenia, OCD, beyond which, even when we look at things like autism, we know that there's high co-occurrence with other conditions. One paper has it as high as 70% of individuals with ASD also have some co-occurring condition like social anxiety conditions. So again, when we think about kind of undiagnosed high-functioning neurodiverse individuals, then another way maybe is this kind of indirect way of screening for some of the other things, and that could be a way as well of improving early identification of things like ASD. Second prefatory remark is that when I refer to emotional, behavioral, and mental health problems, I do so only insofar as what I'm suggesting is that some children are more likely than others to be at higher risk of developing emotional and behavioral patterns, which from their perspective and the perspective of their parents cause some kind of constraints on social functioning. I make no normative judgment, that is, on whether the impairment is actually something that we see as a biological impairment or whether this kind of constraint on functioning is actually something that really derives from social prejudice. Again, the spirit of neurodiversity suggests that really what we want to do in the long term is move from a model where we focus on individual biological impairment to really focusing on the reconstruction and reconfiguration of social and cultural institution and norms and customs such that we're seeing neurodiversity as normal variations on the human condition. Of course, this takes time. This is the ultimate aim, if you like. What I want to do is focus on what we can do in the short term to maybe improve current diagnostic pathways, as Jenny introduced, to enable better identification of those with neurodiverse conditions to provide the support that they could benefit from. This is where screening comes in. So before talking about school-based screening for general emotional and behavioral needs, what I want to do is make a couple of remarks about specifically autism. Because, again, as many of you know, and as we'll hear, really what we want to do is shift the diagnosis to the point where it's occurring in the preschool period. Again, Tom and Mel can really speak more to the UK context. What I want to do is talk about maybe some points from the US context where I'm currently based and kind of get the dialogue going to see how things compare. So some figures here. I mean, in contrast, actually, to very recent research that's just been published for the UK, where using the GPRD, the General Practice Research Database, it was suggested that rates of autism prevalence have actually remained quite constant in the UK over the past decade. In the US, we see something very different. So over the last 10 years, 2000 to 2008, autism prevalence has actually been doubled. So, I mean, but of course, what this does is that it looks at, these prevalence estimates are based on secondary review of clinical and special educational needs referral records. So our estimates are only as good as the information recorded by clinicians or those performing these kind of referrals. So, if nothing else, a very simple and important point is that screening is a way of gathering more robust actual prevalence data. This might be a fair comparison, but the difference between kind of systematic census records to those who turn up to vote, just as a kind of an analogy. So the limitation, obviously, of epidemiological surveys is that extrapolating from a sample doesn't allow us to actually identify those children who need support and resource. So the challenges with autism, as I understand, is to reduce current diagnostic delays such that children with ASD can be consistently diagnosed before they're actually even in school. The US government recommends that at these well-child screening visits, developmental disabilities are kind of routinely screened for by primary care physicians at 9 months, and then at 18 and 24 months, there's a more kind of formal routine investigation of ASD. So that's how it should work. Obviously, in practice, what we find is that 4 to 6, according to the literature, in the US, is the average age for formal ASD diagnosis. Those are the latest I've got for that. And actually, only 1/3, and this is partly probably why the average age is later than these kind of well-child visits, is that a proportion of US doctors only routinely screen for it, so they're not technically doing what they ought to. Which, again, brings me to a need to more systematically screen for these conditions. Many of you might have heard of this, any head nodding. This is recommended by the American Academy of Pediatrics, and it's called the MCHAT-RF, which stands for the Modified Checklist for Autism in Toddlers, revised follow-up. So it's been a lot of work in the progress. And it's actually a 2-stage screening for ASD. It's free to use, doesn't require any additional training by medical practitioners. And it's just a very simple 20 yes-no question survey in the first stage, with those who screen positive at that stage being, kind of invited to have a follow-up interview. That is, the parents are invited to a follow-up interview by professionals, doctors, and their assistants for further investigation. And we've also got very recent published over the last few months validation studies of this tool, and it shows pretty good diagnostic accuracy. I mean, overall, what the researchers doing that validation found in their research is that it reduced the number of years, the implementation of universal screening reduced the average age of ASD diagnosis by 2 years. But again, this was a systematically, universally, routinely administered survey. So I want to move now to kind of what I've been particularly involved with recently, which is moving from autism and kind of neurodiverse conditions to generally this model of emotional, behavioral, and mental health checks in schools. Obviously the costs of emotional, behavioral, and mental health problems to society cannot be overstated. In the US, it costs $318 billion is the total cost of serious mental illness to society, which is roughly 1.5 times the cost of all cancers. See something similar in the UK, where it's £105 billion that is spent on mental health problems, broadly construed, of which I think it's £21 billion is actually spent on health and social care, which again is double the annual spend on cancer treatment and diagnosis. So it's obviously a very serious problem, and I've spoken to a couple of you beforehand. Hopefully we'll have discussions afterwards, but part of the reason why I feel universal screening is so important is that research suggests that roughly 3/4 of serious mental illness in adulthood has its antecedents in childhood and adolescence mental health problems, half of which could be diagnosed by the age of 15. There's increasing evidence which suggests not only that early intervention in emotional, behavioral, and mental health problems can be beneficial in terms of treatment and health outcomes, but also can be cost-effective to society in the long run. So really, when we talk about parity of esteem, or when the UK government talks about parity of esteem, my thoughts is really what we should be talking about is priority when it comes to mental health. So why screen universally in the school? A couple of other options that might be at our disposal: targeted screening. I mean, this is where you kind of single out, if you like, specific demographic groups that are traditionally at risk. I think this is insufficient, not least because of the issue of stigmatization. I mean, if you're singling out certain groups of children on the presumption that they're more likely to have, mental health issues, then, that could lead to stigmatization. Also, we miss certain children. I'd be interested to hear, again, one of the framing points that Jenny made is, a lot of children with neurodiverse conditions can be quite easily missed. How does the prevalence relate to certain demographic characteristics like socioeconomic status, ethnicity, race, etc.? I'm sure some of the other experts here can talk about that. But even when we think about things like social anxiety, internalizing behaviors, these are as common, if not more common, amongst, for instance, higher SES children. We could also do screening in the pediatric setting, so in primary care, for instance. Left off the references there, sorry. See me later for those. But there's 3 systematic reviews which actually have looked at this, and they found that it's limited. That is not to say that potentially pediatric screening couldn't work, just that we haven't got the evidence that it does work in terms of long-term health outcomes. However, I think we have reason to believe that it's actually, in principle, better to do school-based screening because it's more equitable. I mean, all children have to go to school. The UK, as many of us will know, is particularly bad for organic help-seeking behavior. That is, we don't like going to the doctors. Maybe we don't like taking our kids to the doctors, So I think there's issues why I think using school-based screening could actually be desirable. But we obviously need evidence for this. We also, in order to have the evidence, need additional resource and support, which I think is not particularly forthcoming. So this is some of the coverage from the BMJ paper that we published are making this argument for the need for universal screening. And, and ultimately what we found is that, some of the national kind of key figures, related to this policy that were quoted in the media actually said, well, what we need is more evidence at the local level. Also, I had a lot of people contact me after the paper was published that were involved in local policy. So, mental health leads on clinical commissioning groups, for instance. And what they were saying is that they can't really do anything until we have a national directive. So there's this kind of, we're caught between a rock and a hard place, between the Charybdis and the Scylla of the public health, pediatric policy paradox, if you like. So we're kind of stuck. Part of it is there's these kind of these easy canned criticisms of why screening isn't a good idea. So I'm just going to kind of quickly outline these and then give you my kind of counterpoints as to why I think actually it is a good idea. How am I doing for time, by the way? Oh, okay. Am I talking too quickly, by the way? Just trying to cover a lot. Sorry. So it is possible, so this is the criticism again, that, screening leads to labeling and stigma. And I mean, part of the reason I thought this event was amazing is because in the initial email that Jenny sent to me was labeling might not be a bad idea. And, I've had conversations with a couple of you, and it kind of really spoke to me, because I think it's possible to have too much of what we might call demedicalization. There's this real trend towards being very skeptical over medical diagnoses. A lot of people point to what in kind of the sociology of medicine is being called the pharmaceuticalization, the fact that, what we want to do is get our children and fill them full of, kind of anti-ADHD medication. My view is quite the contrary, that actually, we want to find more organic sources of counseling and support. We might not even need to go that far, but anyway, I think, nothing in my mind could be further from the truth that we need to automatically jump to medication. I think actually as well, universal screening can be destigmatizing. I mean, common sense, I would think, would dictate that unfamiliarity drives prejudice, so that the more familiar something becomes, the more open we are about it, the more normalized it becomes. And actually there is evidence in the clinical setting when people looked at these screening programs that doctors were doing, it meant that they found that afterwards, parents, children, and doctors themselves were more open to talking about emotional, behavioral, and mental health issues. Second criticism is that screening, creates these false positives. I mean, I think first of all we have to ask what is a false positive in mental health. Again, we wouldn't necessarily jump to a diagnosis. I mean, that's the most important thing that I try and get across, is that screening in itself only really screens for risk of potential future emotional, behavioral, and mental health disorders. So really all we're doing with the primary screening is looking to see, kind of assess where a child stands in terms of their current emotional functioning, should we say. And I don't think we should place equal weight to a false positive with the risk that goes along with not diagnosing, not looking for something, if that makes sense. And also we can work to improve accuracy. Mental health is very fluid. It's not like some physical, somatic problems and disorders where, it's positive, negative, you have some kind of operation afterwards. I mean, it's, the risk, I think, of false positives, particularly, again, if we work to destigmatize the terms autism, the terms ADHD, the terms depression, etc., the term schizophrenia, then, what consequence is the label? So the third criticism is that screening would be widely opposed by parents, but nobody's actually asked the parents, not in the systematic research studies, so that's something we're working on. And also we can look at those studies of screening programs which do exist. We can look at participation, consent, return rates, and the consent is actually relatively good as any research study is. So that suggests to me that parents wouldn't automatically be opposed to this idea, provided we move to the next criticism, provided follow-up support and resource can be provided. There is actually a large UK-based ADHD trial where they had a few arms, but one of the arms of the trial actually screened for ADHD, but it gave the names of those children who screened positive for ADHD to the classroom teachers, but didn't provide any additional support and resource. One of the other arms did, but what they obviously found in the arm of the trial, which they screened the children, gave the positive records to the teachers, but didn't give them any support, is that health outcomes were actually poorer in the 5-year follow-up, which makes sense. I mean, if you're going to screen someone, then obviously you want to provide some kind of intervention thereafter. Again, it just comes back to this idea. I think, yes, obviously there'll be short-term costs incurred if we try and implement any policy, any intervention, but there's a lot of research. I think it's at the London School of Economics where they've actually, again, argued that this could, they've done some modeling work and they've suggested it could lead to long-term cost savings. So, yeah, again, it comes back to this idea. If we think something's important enough, then obviously there is a finite, pot of money, but I think more money needs to be directed towards neurodiversity, towards emotional, behavioral, and mental health services. I think am I doing for time?
Just about okay.
Okay, you sure? So maybe I'll just kind of give you a really brief, sorry for this whistle-stop tour, but I did, again, in keeping with this idea, screening in itself is ineffective unless we can do something to follow up. I just really want to give a shout out to this intervention, which I think at the moment is having very positive findings, but it's based on a referral system. So I don't know if anyone's heard of Place to Be. Effectively, it's a school-based counselling service which has good national reach. I mean, it's in 169 primary schools in the UK, England and Wales, and Scotland. And that's the total amount of children that are actually within its kind of remit, if you like. So it's really a giant intervention in the way that only the voluntary sector can do, because of people like yourselves that are really committed and actually want to get something done. So I think us researchers could learn a lot from people that actually want to get something done and evaluate it at the same time. So it's actually a 3 kind of stemmed approach to providing support for children in schools. Something called Place to Talk, which is a lunchtime drop-in center that children can self-refer, and they go in and they talk to mental health professionals about whatever problems, which I will quickly show you a slide on. And a third of the children actually went to that Place to Talk. So these are the kind of things that they talk about. I don't know if you can see the writing. It might be a little small, but just kind of things that are kind of sometimes referred to as normal kind of child behaviors and emotions, but again, chronically, cumulatively, sometimes when you have problems to do with friendships, emotional issues, they build up, and they can kind of actually cause kind of harm in the long run. In addition, they can be like investigative assessment cues, if you like, to those working in child and adolescent mental health for later problems. And there's also a counselling service, which again had relatively small attendance, and this, I guess, returns me to my earlier point. 5.6% of the total school population attended either a group or one-to-one counselling. But we do know, again, if through epidemiological literature, that really when we talk about, emotional and behavioural and mental health problems, in youths, it's more like 10 to 25%. So I think, again, this is indicative of the fact that any referral system is limited insofar as there's always going to be children that slip through the net for various reasons. Universal screening for risk could be a potential solution. And this, again, is their findings from this intervention, that only 50% of the children that they actually found their way either through parent, teacher, or child self-referral to the place to be counselling services. Only 50% of the children had previously seen some kind of professional mental health or special education individual. And just really briefly, because I know I'm running over. So 70% of children improved well-being. We had a mean total SDQ change. The SDQ is something called the Strengths and Difficulties Questionnaire. It's basically the screening tool that the team used to evaluate whether there was positive change, whether these children moved from kind of negative emotional and behavioral health status to more positive. So that was a pretty good result. My argument is that we should be giving it not just to the children that refer themselves or have their parents refer them to these services, but we should be giving it to the whole school population. And these are the children, again, in the abnormal clinical range. I mean, and these tools do use this kind of clinical terminology, but again, what they found is there was pretty significant, statistically significant change in that a far larger percentage of children came out of the abnormal range post-intervention. Yeah, and future directions, I mean, that's what we are working on now, this idea of why not use the screening tool in the, and actually, we can talk about this maybe in the questions afterwards or discussion, but it does include like a hyperactivity scale, for instance. So this SDQ is a good kind of really early broad screen, which might really pertain to neurodiverse conditions. So what we're hopefully going to do in the not too distant future is a pilot randomized control trial where we look at screening in the whole school population and to follow it up with this school-based counselling intervention. So hopefully Jenny will invite me back and I can talk to you some other time about that. So that's just the research question. Thanks for your time.